I'm Rebecca Marmore. I'm a Johns Hopkins vascular surgeon. I practice out of Howard County General Hospital. Peripheral arterial disease is the hardening of the arteries. Most patients have heard of coronary artery disease, also known as CAD. Well, the same process is happening all over a patient's body. So we can get hardening of our arteries in our neck, in our legs, in our arms. It's a diffuse process that affects all arteries in the body. Risk factors for PAD include smoking. It's probably the #1 risk factor we see amongst our patients. Additionally, patients who are older, have chronic kidney disease or are on dialysis, have diabetes, have a family history of PAD. Patients who have coronary artery disease or have had a heart attack are at risk for PAD. Additionally, it's more common in males, although we do see it frequently in females as well. PAD presents in a variety of ways. So sometimes patients are referred to my office because their primary care doctor was unable to feel pulses in their feet and gets an imaging study which shows they don't have normal blood flow to their feet. At the most serious end of the spectrum, patients have what's called tissue loss, or wounds that are not healing because of poor blood flow. In the middle of the spectrum, patients often complain of leg pain when walking. This is called claudication and is one of the most irritating manifestations of PAD to our patients. For patients with the most serious manifestations, the tissue loss or wounds that are not healing, most of them will require either open surgery, such as a bypass operation, or an endovascular procedure, such as a balloon or a stent in their artery, to restore blood flow to their leg. For patients, however, who have either asymptomatic PAD or claudication, I typically recommend 2 primary things. 3, if you think about it. The first is I make sure they're on the correct medications. So for our PAD patients, that would be an aspirin and a statin. Second, for patients who are smoking, I emphasize that quitting smoking is of the utmost importance. Finally, patients who have claudication most commonly benefit from a dedicated walking program. Patients with claudication often will benefit from a dedicated walking program, and they're usually really unhappy to hear that this is my recommendation because they come in complaining of pain with walking. However, I tell them that their body is really magical and is actually able to develop collaterals or detour routes around the blockages that they've developed over the course of their lives. What is a dedicated walking program? They want to know. It's very simple. I tell them they need to walk, and they need to walk until they develop that crampy pain in their calves that they come in complaining of. And when they have that crampy pain in their calves, they can't stop. They need to keep pushing themselves for at least another 30 seconds, 45 seconds, ideally a minute. And after that, then they're allowed to stop. Once they stop, they typically get relief of their symptoms, and when they're ready to go, I want them to carry on. And I want them to do this for another 2 or 3 sessions. And what they find is truly remarkable. They come back and they tell me, "Doctor, I used to only walk 2 minutes before I'd get this crampy pain. But slowly and surely, with dedication, all of a sudden they're walking 5, 10, 15, 20 minutes.